morning to everyone. I come on behalf of Dr. Rubinstein from the Ministry of Health and Social Development. And actually, for us in Argentina, the public policy that we are implementing is universal health coverage. So the access that we know that's universal is not as effective in care as it should have. So we had proposed this as a national policy. I bring a 3-minute video to share with you, and then we will talk specifically in relation to palliative care in the public health of Argentina. Could you please run the video? Universal health coverage. We may say that in Argentina there's universal health coverage because 100% of the Argentinians and residents have the right to receive medical care in any public institution, either public hospital or primary care center. The reality is that that universal coverage is just a name because it's not linked to an effective and guaranteed quality coverage. This is a major conceptual difference between what we have now and what we want. The model of implementation that we are promoting and working has to do with coming out from a aspirational care coverage. Universal coverage implies to get the health services toward the people, to work together with the different provinces. We need to go towards a road that will legitimize the services that we are covering. And this has to do, therefore, with a model where we start to prioritize those conditions for which the differences are inadmissible, that have to do with territorial coverage, focus on primary care, with family care teams. Why do we talk about community and family health? Because the problems that people present occur throughout the country, and we need to generate teams that will work together with these people, together with those individual families and communities, to be with them and provide answers to those health problems. Also, to work in the process of digitalization of the electronic clinical record, the quality of the patient care, because each physician who takes care of the patient has a different vision. He can see information from the entire life of the patient with the images results, lab results, and with better information we can provide better care. CUS means that you don't have to go to a hospital at 4 o'clock in the morning for an appointment. To have a general practitioner that could be his physician that they trust. So this is a medical team that will back these, and in many cases when they have to refer to a specialist, they can have instruments such as remote consultation, teleconsultation, and there is a clinical record that goes along with the patient. It's to provide closeness to the care. The frame to guarantee that accessibility is universal coverage has 3 lines, shown digital health, community and family health, and the increase of coverage and effective coverage that doesn't depend on where you're born or where you live in order to receive a differential care, because palliative care, when these are mentioned of the large number of Argentina, the presentation by Dr. Tania, we saw that this is a country that is numerically well, but there's a big gap what has to do with Social Security, the private sector and the public sector. And in the primary health care, there are almost no services for palliative care. So if we think in this palliative care with nuclear teams, with general practitioners, nurses, health agents organized by areas, and every sanitary agent is in charge of a micro area with expanded teams with other disciplines such as psychologists, social workers, kinesiologists, and other specialists who work with the core teams and these matricial support teams with a specialized effort where we think of others medical specialties to go together with the core teams to solve the problems of the first level of care and also palliative care, but a major goal is to provide competence to all these core teams so they can solve and be next to the users who have suffering, pain, health problems, and that palliative care can be the solution for that, for those teams. This is the working logic with matrix support. This is the idea of implementation of coverage on how we will be working until 2022 in the identification of the users. And under this frame of palliative care, we are working in the implementation of a home care team. Those core teams not only treat in the health post or in facilities, but could also go to the home of the patients and either at the end of their life or when they are chronic pain, is at the home of the patient with the staff who works in that first level of care. These are the principles of palliative care in the first level of care. The networking, the national public policy, together with humanization of practices, comprehensive care. All these lines of care are prioritized in health universal coverage that has to do with chronic conditions, and among them we have cancer, but we also have all these conditions that may generate a different type of life for those users. At this stage, we are strongly working to train the teams at the first level of care for palliative care. Today, these practices are basically provided in the second or third level of care. Our goal for the coming 2 years is that the first level teams will provide an answer in palliative care, and for that we need to make sure they're well trained. We have a reorientation program for physicians. This is something regional, the lack of family physicians or general physicians, and we think that this is the most important human resources to provide answers at the first level of care and including palliative care, and these are the program actions together with different areas from the Ministry of Health, like the National Cancer Institute, in the area of universal health coverage with medications. There's planning, training for all these teams of the first level of care. I'm sure this afternoon the people from INCA will talk about purchase of opiates made, such as morphine and methadone, but there's no point in having them. We need physicians to prescribe them, and not only prescribe from the hospital, but also prescribe them in the health posts. And finally, a quote that I like. You know that in Argentina there is some changes. The Ministry of Health still called Ministry of Health and Social Development, but our minister is a Secretary of Government, and the rest of the structure did not modify, and we have complicated times where to plan for hope is the only reason that allows us, for all the workers in the health sector, to continue struggling on a daily basis to change reality. Thank you very much.